complications. Our last lecture, we talked about classification of transfusion reactions. Okay, we classify them into acute transfusion reactions and delayed transfusion reactions, and also classify them based on whether the reaction presents with fever or not. So we have gone through acute transfusion reactions, those that present with fever and those that present without fever. We've done all that. So today we are going into delayed transfusion reactions, and we're going to finish up with transfusion reactions today. Okay, so today, delayed transfusion reaction, immune-mediated complications and management. Comprehensive overview of pathophysiology, clinical features, and prevention strategies. So once again, delayed transfusion reactions, we classify it based on whether it presents with fever or it does not present with fever. So there are so many ways of actually classifying transfusion reactions, but the most crucial point you should be able to realize or know is that any transfusion reactions you are dealing with or you are trying to explain or talk about, you have to be able to make sure that you know, is it an acute transfusion reaction? Does it present with fever or not? So many of the clinical presentations surrounding the transfusion reactions. Okay. So we have delayed transfusion reaction, the classification. Those that are presenting with fever includes delayed hemolytic transfusion reaction. Okay. Okay, we have transfusion-associated graft versus host disease. It's also a delayed transfusion reaction that presents with fever. Among those that don't present with fever, we have delayed serologic transfusion reaction. We have post-transfusion purpura, and we have iron overload. Okay. So delayed transfusion reactions, definition and overview of, we just have to take an overview on this slide. Okay, right. Okay, delayed transfusion reactions are immune-mediated complications. Immune-mediated complications occurring more than 24 hours to weeks, okay, after transfusion. From more than 24 hours to weeks after transfusion. We call them delayed transfusion reactions, and they represent a significant concern in transfusion due to their clinical implications or clinical significance. Like I said in the initial slides, that some of them present with fever, while some of them don't present with fever. Also, this slide tried to also show that those that present with fever, delayed hemolytic transfusion reaction, transfusion-associated graft versus host disease. Okay, on this condition, they are characterized by immune responses that can lead to severe complications. We have also the delayed serologic transfusion reaction, which is a delayed transfusion reaction that presents without fever. Okay, so also post-transfusion purpura, okay, presents without fever, and then iron overload. Okay, so delayed hemolytic transfusion reaction, that is one of the delayed transfusion reaction that presents with fever. The delayed hemolytic transfusion reaction occur due to secondary immune response against donor red cell antigens between 24 hours and 28 hours post-transfusion. The red cell antibody screen is negative before transfusion, but hemolysis ensures later. So in this transfusion reaction, prior to the transfusion reaction, the screen for the antibody on the patient was negative. But during the process of transfusion reactions, there was hemolysis was observed. Okay, So if it occurs like that, we may suspect delayed hemolytic transfusion reaction. The incidence is from 0.26% to 2.8 of transfused patients. This highlights the relatively rare but significant occurrence of this reaction. Okay. The mechanism of hemolysis in delayed hemolytic transfusion reaction typically cause extravascular hemolysis via the IgG antibodies coating red cell, and this leads to their removal in the spleen and liver. Okay, so observing the peripheral blood smear, okay, observing the peripheral blood smear will show the presence of spherocytes. Okay, it's very, very diagnostic of delayed hemolytic transfusion reactions. Spherocytes, because there's extravascular hemolysis that is going on. Okay, some of these antibodies, like the KID antibodies, can cause severe intravascular hemolysis by fixing complements, and this represents a more dangerous form of hemolysis in delayed hemolytic transfusion reaction. So in as much as we normally experience an extravascular hemolysis, but if KID is involved, it can cause an intravascular hemolysis, which is quite severe. So what is the pathophysiology of delayed hemolytic transfusion reaction? The first is memory response. Okay, the body tend to recall memory. You know, in immune response, at the first time of exposure to an antigen, the body tries to respond, okay, by building up antibodies against such antigens that in the first exposure, okay, the body may not be able to mount adequate immune response, but because the body has been exposed to such an antigen, it builds memory so that if it encounters such exposure again, it will be able to mount an immune response. So delayed hemolytic transfusion reaction uses such mechanism of memory recall to, it's one of the pathophysiological mechanism for manifesting or for delayed hemolytic transfusion reaction. So the first mechanism may be memory response, recall to memory, memory response mechanism. So here, initial antigen exposure. Initial exposure to a non-ABO red antigen leads to antibody formation. Okay, these antibodies fades below detection over time. Okay, so over time they may not be detected, but the exposure has happened and the memory of it has been registered by the immune system. So that re-exposure to that specific antigen, subsequent transfusion or re-exposure, the patient of the patient to the antigen, this triggers rapid IgG antibody production. Okay, secondary immune response. Okay, the rapid secondary response causes hemolysis. This occurs despite a negative pre-transfusion antibody screen. Okay, because we said initially a patient, we assume the patient had been exposed to that antigen, then the patient come for blood transfusion, but because the level of that antibodies are low or they fade below, we may not be able to detect them. But in transfusion, we're able to observe that there is what? Hemolysis that occurs. This occurs despite negative pre-transfusion antibody screen, because why? Those antibodies, that first exposure tend to fade away, okay, tend to fade, so that any other exposure will now be able to mount an equal immune response. Trying to admit these people. Okay, so common antibodies that are involved on the pathophysiology of delayed hemolytic transfusion reaction include the KID, Duffy, Kell. These antibodies are frequently implicated in delayed hemolytic transfusion reactions. So the first mechanism, the pathophysiology of delayed hemolytic transfusion reaction involve memory recall, memory response mechanism. We have another mechanism that is the primary response mechanism that it may not be common, but it postulates that at the initial first time of exposure, the patient mounts the immune response. That is primary response mechanism. It's less common, okay? Delayed DHTR arises from a primary immune response. Patients form antibodies quickly upon first exposure to a non-ABO cell antigen. So in the first time of exposing the patient to the non-ABO antigen, the patient is able to form antibodies immediately. That's the primary response mechanism. That there will be immediate attack on transfused red cells. Those antibodies attack transfused red cell immediately. So those red cells that are being transfused into the patient was able to immediately develop an antibody against those red cells, and also attacked the red cells that are being transfused immediately, causing extravascular hemolysis. This process leads to the destruction of red cell outside the blood vessels. The IgG antibody coating. The IgG antibodies coat the red cell, leading to their removal in the liver and spleen. This mechanism is a hallmark of extravascular hemolysis. On looking at the peripheral blood findings, you find spherocytes. These are red cells that have lost their normal shape due to antibody-mediated damage. The kid antibodies cause severe hemolysis, just like we said earlier. KID antibodies cause severe intravascular hemolysis by complement fixation, because this antibody KID is able to fix complement, and if it's involved in delayed hemolytic transfusion reaction, can actually cause intravascular hemolysis. This type of hemolysis occurs within the blood vessels and can be life-threatening. So what are the clinical features and laboratory findings in delayed hemolytic transfusion reaction? We can find delayed clinical presentation can vary from asymptomatic to fever and anemia of unknown origin. Mild jaundice or sclera icterus may also be observation in affected individuals. Can also laboratory the serum and that laboratory investigation. Icteric serum positive direct antiglobulin tests with mixed field pattern are always key findings too. These laboratory results are indicators of hemolytic process. We also red cell antibody identification. We have that a newly identified red blood cell antibody is also a hallmark of delayed hemolytic transfusion reaction. And this finding is very critical for confirming the diagnosis. So because in this type of transfusion complications, we are querying the development of a new antibody. Okay, so if we can actually identify or prove the existence of a new antibody that was not there prior to pre-transfusion screening, it confirms our suspicion of a delayed hemolytic transfusion reactions. So we also find spherocytes on peripheral blood smear. Okay, Okay, in the biochemical markers of hemolysis are also present. That you have elevated lactate dehydrogenase, indirect bilirubin levels are commonly observed. Okay, these markers reflect increased red cell destruction. So we for the So transfusion-associated graft versus host disease. These are rare but are nearly always fatal complication occurring within 30 days after transfusion. It results from engraftment of viable donor T lymphocytes attacking recipient tissue. So in graft versus host disease, the implicated antigen are the white cell antigens. Normally during blood transfusion, I always tell you that we don't screen for white cell antigens. We only screen for, most of the times in our setting, we majorly screen for red cell antigens and antibodies, especially in white blood cell transfusion. We don't really go out to cross-match the white cell antigens, but these white cell antigens have the capacity to elicit immunological responses. So, and they are the culprit in transfusion-associated graft versus host disease. So, in this condition, the T lymphocytes attack recipient's tissue. So, but certain conditions must be met. This is, we're going to start. Okay, so we said for this white blood cell antigens to cause immunological responses, certain conditions have to be met. That number one, we say that this white cell antigens, that is, that they have transfusion of viable active T lymphocytes is a necessary condition. So as we are transfusing the blood, we did not separate the white cells from the red cells, and these white blood cells are viable. That is, they are viable. Okay, they can elicit immunological response, and the minimum number of T lymphocytes required for this condition is unknown. We don't know whether if 10 lymphocytes is part of the red blood cell we transfuse can elicit this response, or how many lymphocytes or one lymphocyte. The only condition in this aspect is that the lymphocytes has to be viable. Okay, so when you do your vital staining, know whether the cell is viable. So the T lymphocyte has to be viable. Once they are viable and they are contaminating the red blood cells that we are transfusing, that it's able to elicit an immunological response. So that is one condition that have to be met, that the lymphocytes that are contaminating that are parts, we won't say that they are contaminated, that are part of the blood that are being transfused, that is red blood cell, that they are viable. The second condition is that HLA match, just like what I was explaining to you, that we did not cross-match the white cell antigens when we are doing blood transfusion. We only cross-match for red cell antigens. So the TAGVHD occurs when the donor and recipients are not HLA identical. When we talk about HLA, we are talking about human leukocyte antigens. Human leukocyte antigens, and these are the white cell antigens, and we don't cross-match for them in the process of blood transfusion, but they can still cause immunological responses. This mismatch allows the donor T lymphocytes to recognize recipient tissue as foreign. Okay, so because they are not cross-matched and the T lymphocytes are viable, they can recognize the recipient tissue that they are foreign. Because These phones are calling me, stopping my lecture. The donor T lymphocytes can now recognize the recipient tissue, the patient that is receiving the blood that is being transfused. The lymphocytes in that donor cells can now see the recipient's tissue as foreign, and they will start attacking the recipient tissue. That's another. These are the conditions. Then the condition number 3 is that immune response deficiency. So even though the transfused lymphocytes are attacking the recipient's tissue, okay, the recipient tissue under normal circumstances should be able to mount an immune response against that attack. But sometimes this does not happen, or it does not happen sufficiently to counter attack. So if there is immune response deficiency, okay, it can now give rise or um, give rise to transfusion associated graft versus host disease. So the recipient must be unable, this is another point to be met, the recipient must be unable to mount an immune response to neutralize transfused lymphocytes. This inability allows the donor T lymphocytes to proliferate and attack the recipient's tissue. So just like the process of immunity, immune response we talked about, your normal immune response, that if there's an attack, the body should be able to send a counter attack. But if that is not possible, then the initiated attack will continue to increase until it causes damage and harm to the recipients. Okay. So just like I was trying to explain the pathophysiology of transfusion-associated graft versus host disease is immune interaction. If you look at this slide, looking at this slide, okay, you can see these first slides. There was an attack, okay, an attack on this tissue. But you can see the tissue responded by releasing counter immunological response to attack this foreign uh, cells, okay, and it leaves his tissue alone. It counter attack it. But when you look at this process, for example, if the patient is an immunosuppressed patient, okay, there's an attack, initial attack, you can see the cells attacking the tissues of the body again. But here, there was no immune response. The body did not respond to counterattack this immunological reaction that is going on. So it continues to mount up until it destroys this tissue, resulting in graft versus host disease. So donor cell initiates the attack. Donor T cells, okay, like their CD4, CD8 on NK cell, recognize and attack foreign host HLA antigens. This marks the beginning of the immune interaction in transfusion-associated graft versus host disease pathophysiology. Okay, host immune counterattack. Host immune cells, like also the CD8, the NK cells, counterattacks and neutralizes donor lymphocytes. Okay, that is the expected outcome. This step is crucial to prevent the persistence of donor T cell. Okay, but failure of that neutralization, failure of host neutralization, allows donor T cells to persist and attack host tissue. This leads to the development of TAGVHD, and that is the pathophysiology of graft versus host disease, immune interactions. Okay. So I've taken time to explain that. So the clinical presentation of TAGVT, symptom onset. Symptom typically develop 7 to 10 days after transfusion. This time frame is crucial for identifying it. The initial symptoms include fever, okay, rash, okay. Okay, we have gastrointestinal manifestation, we have hematological impact, pancytopenia progress to myeloaplasia. Okay, fatal outcome, marrow failure often leads to fatal infections. These infections are a direct consequence of the body's inability to fight pathogens. So these are some of the clinical presentation of TVHD. Okay. So prevention, how can we prevent transfusion-associated graft versus host disease? You've seen the pathophysiology. So the first line of prevention, if we can irradiate blood products. Standard prevention involves irradiation of blood products to inactivate the T lymphocytes. Okay, a dose of 2,500 GY is targeted to the center of the blood bag with a minimum of 15 GY throughout the body. So those in radiography will explain that better. The dose of the rays, activation irradiation to be given. Okay, effectiveness of irradiation. Irradiation deactivates T lymphocytes. Okay, it activates the lymphocytes without damaging other blood cells, okay, because it's targeted to the T lymphocytes. This ensures the safety and functionality of the blood products for transfusion. So looking at the pathophysiology and how it initiates because of the viable T lymphocytes that are being transfused from the donor to the recipient. So before the transfusion, if the blood can be irradiated to deactivate those active lymphocytes, T lymphocytes, it will help, okay, to eliminate this condition. Okay, another practice is to do leukoreduction, that is reducing the amount of white blood cells that are contaminating blood products, the red blood cells. Okay, the amount of white blood cells, you know, when we are doing blood donation, we talked about leukoreduced blood. So this is one of the reasons why it is important to do leukoreduction of blood, okay, because of this complication of transfusion. So, but it has its limitation. Leukocyte reduction alone is insufficient to prevent this disorder. Causes of this have occurred despite leukoreduction, highlighting the need for irradiation, okay, if it's possible in our setting. All right, but there are some patients that are quite at risk of developing this graft versus host disease. Again, looking at the pathophysiology, one of the conditions we stated is that the patient will be unable to mount an immune response. Okay, so these patients that are at risk of developing the transfusion-associated graft versus host disease are number one, immunosuppressed patients. You should be able to explain that. Immunosuppressed patients that are unable to mount immune response. Those with hematological malignancies. Patients with hematological malignancies, particularly Hodgkin's lymphoma, are at high risk due to inherent immune defects. They also have inherent immune defects, and this immune deficiency makes them more susceptible to complications, okay, like TAGVHD. Okay, neonates and transfusion. Okay, neonates receiving intrauterine premature or exchange transfusion are at significant risk of this complication. These procedures involve exposure to donor T lymphocytes, which can trigger the condition. Granulocyte transfusion recipients are also at risk. These recipients are at risk because this transfusion contains viable T lymphocytes. The presence of this cell can lead to the development of TAGVHD in vulnerable patients. So patients that are unable to mount immune response are actually at risk of developing transfusion-associated graft versus host disease if they are exposed to any form of transfusion. Another special risk factor, HLA match blood from relatives. Mechanism of one-way HLA match. Okay, when I will explain this this slide using this diagram. Just zero your eyes to this diagram, okay? So this is the donor, okay? So in families, sometimes we are not homozygous for the same HLA antigen. We may be heterozygous, okay? So this is the donor, this is the recipient. You find out that for this antigen, leukocyte antigens, this donor is homozygous, okay? It's homozygous for this antigen. They are picking a particular white cell antigen, and the donor is homozygous, but the recipient is heterozygous, okay? Okay, so when this donor cells is transfused to these recipients, see, so the recipients, okay, this recipient will see this donor as itself, because he has this heterozygous for the antigen the donor is is heterozygous for it. He has a complement of it. So when the blood is being transfused to this recipient, the recipient immunologically goes to sleep because he's not seeing any danger. The recipient himself will not see any danger because he has part of what is coming from the donor. But now that those donor cells that are being transfused, white cells, will see this recipient's antigen as foreign. You see it? You see this recipient antigen as foreign, and then we'll start attacking the recipient without the recipient mounting, because the recipient is not seeing any danger. He will not be able to counter attack this transfusion. So he will relax while the donor red cell are attacking its cells and causing tissue damage. So this is another mechanism of, apart from those that are immunocompromised or immunosuppressed, this type of cross-matching, one-way HLA cross-match from relative, can actually initiate graft versus host disease. The HLA heterozygous recipients, okay, receive blood from HLA homozygous donor sharing one haplotype, okay. Donor T lymphocyte recognizes recipient's non-shared haplotype as foreign and attack. That's what I was explaining to you, okay? Absence of counter-attack by recipients, okay? Recipient immune system does not recognize donor cell as foreign, does not recognize it. This lack of recognition prevents any counter-attack against donor cells, okay? So the attack of donor T lymphocytes leads to transfusion-associated graft versus host diseases. This can occur even in immunocompetent recipients, okay? Those that can, that is, patients that are normal in all aspects, they can mount immune response, they are not immunosuppressed, but because of this one HLA match, okay, this transfusion versus graft versus host disease, transfusion associated graft versus host disease can also occur in them if we have one HLA, a one-way HLA match, okay. Okay, so delayed reactions without fever. We have seen the two delayed reactions that occurs with fever, delayed hemolytic transfusion reactions and transfusion associated graft versus host disease. Now we have delayed serological transfusion reactions that presents without fever. This is defined as the detection of a new clinically significant red cell antibody in a patient transfused between 24 hours and 28 hours earlier. No evidence of hemolysis is found throughout the evaluation. Okay, no evidence. We have to distinguish it from delayed hemolytic transfusion reaction, where we find hemolysis. Okay, delayed serological transfusion reaction, no hemolysis. Delayed hemolytic transfusion reaction, we have hemolysis. Delayed DSTR requires the absence of hemolysis. Any hemolysis exclude DSTR and distinguishes it from delayed hemolytic transfusion reaction. Okay, we have a post-transfusion purpura. Okay, definition and risk. Post-transfusion purpura is a rare immune-mediated thrombocytopenia occurring about 10 days after transfusion. It is characterized by a sudden drop in platelet count due to immune response. Post-transfusion purpura, this has to do with the platelets. You find out that in the population, PTP occurs mostly in patients lacking human antigen, platelet antigen, the human platelet antigen 1A. Some persons in the population lack this antigen. Okay, multiparous females are particularly at risk with a female to male ratio of 5:1. So what triggers this transfusion complication is triggered by transfusion of platelets or red cell containing platelet antigens. Okay, we say that some persons in the population lack this antigen. Okay, but when they are transfused with blood that contains this platelet antigen, it tends to trigger an immunological response. Okay, even red blood cell product can contain enough platelets and soluble platelet antigen to initiate this reaction. So the presence of platelet antigens in transfused products is central to the development of post-transfusion purpura. These antigen provoke an immune response in susceptible individuals. So these individuals, some individuals that lack these platelet antigens, we definitely develop this has to do with platelets. Okay, unlike the TB transfusion associated graft versus host disease that are affecting the white cells, post-transfusion purpura is talking about the presence and absence of platelets antigens. Okay, it causes severe thrombocytopenia because the platelets are being destroyed. Okay, it has this mortality risk about 12%. Intracranial hemorrhage is the primary cause of deaths in affected patients because of the low platelets that results from it. Females are predominantly affected because of the pregnancy, higher in those with multiple pregnancies. Okay, antigen association. PTP shows a strong association with the absence of platelet antigen. Individual that does not have this antigen being exposed to it. Okay, bleeding manifestation. Wet purpura is a common symptoms in this disorder. Okay, bleeding manifestation because of the platelet number that is decreased. So person may be prone to bleeding. Pathophysiology of this PTP, we said, is as a result of the anti-human platelet antigen 1. The human platelet antigen 1 are responsible for platelet destruction in about 70 to 80% of cases. Okay, these antibodies target platelet positive, human platelet antigen positive platelet, leading to their rapid elimination. So when somebody that does not have an antigen is being exposed to the antigen, you find out that the antibodies that are being developed will now target the platelet antigens of the recipients and destroy them. Sensitization through pregnancy or transfusion. Someone can be exposed, sensitized through pregnancy or blood transfusion. Okay, exposure, sensitization, someone that is negative being pregnant with a child that is positive for the platelet antigen may be sensitized, or as a result of transfusion, someone that is negative for the antigen being transfused with blood that is positive for the platelet antigen may also be sensitized for it. Okay, impact of subsequent transfusion, so that subsequent exposure will be able to now mount immunological responses, antibodies destroying the platelets. Okay, platelet destruction may involve autoantibody activity or antigen antibody complex absorption. This mechanism contributes to the elimination of both transfused and endogenous platelets. Okay. So treatment of PTP, we can use a immunoglobulin. Intravenous immunoglobulin is the first line. Okay, this approach is effective for most patients with PTP. So why they give the immunoglobulin? Because instead of destroying the platelets, okay, instead of destroying the platelet, the antibody can now destroy eating up the immunoglobulin, and then the platelets can be allowed to circulate for some time. Also, plasma exchange for non-responders. Okay, plasma exchange is reserved for patients who do not respond to uh, intravenous immunoglobulin. It serves as a secondary option to manage platelet levels. Avoidance of platelet transfusion can also help in patients that are negative for these platelets, human platelet antigens. Okay, platelet transfusions are generally avoided as they may be ineffective. Okay, because transfusing the platelets, the antibodies the patients have already developed will destroy the platelets. So transfusing platelets will be ineffective. You transfuse platelets, but you don't get the consequential increase in the number of platelets. Assuming the patient has low platelets and you transfuse more platelets, it's just like as if you're adding a fuel to fire. So that is the scenario it will create, because the platelets are being consumed by being destroyed by almost by antibodies in the body, and you are bringing in more platelets. So it may be a scenario of adding fuel to fire. So avoidance of platelet transfusion. They can also worsen thrombocytopenia in PTP patients. Okay, because of the pathophysiology of the disorder. Is the antibody that should be removed. The antibodies that are destroying the platelets are not removed, and you transfuse more platelets. Those platelets that you transfuse will also be destroyed. Antigen matched future transfusion. So in the future, the patient's platelet antigen has to be matched. Differential diagnosis consideration. Differential diagnosis involve TTP, ITP, DIC, and HIT. Okay. Careful evaluation is necessary to distinguish PTP from these conditions. Okay. Another condition, delayed transfusion reaction, that does not have that present without fever, is iron overload in chronic transfusion. Iron content in red blood cell, each unit of red blood cell contains approximately 200-250 milligrams of iron. This equates to about 1 milligram per mil of red blood cell. Lifetime exposure of 50 to 100 transfusions in a 70 kg person poses significant risk of iron overload. Excess iron deposits in vital organs, causing damage. Affected organs, iron overload leads to deposits in the liver, heart, kidney, endocrine organs, reticuloendothelial system. These deposits result in organ damage over time. Clinical manifestations include hepatic or cardiac failure, diabetes, thyroid dysfunction are common manifestations. These conditions arise due to excessive iron accumulation. Preventive measures. Exchange transfusion can reduce the risk of iron accumulation. This method helps in monitoring iron level efficiency. So, in iron overload, the body does not, you have to bear in mind the metabolic pathway of iron in the body. Now, the normal iron we ingest as food, okay, are being metabolized. by the body. The body handles that iron. But the iron, due to blood transfusion, have entered into the bloodstream. Okay, the body does not have any mechanism of eliminating it or metabolizing it. They are just deposited in these tissues we mentioned here, like the liver, heart, endocrine organs, and the reticuloendothelial system. Okay, so that is one aspect of transfusion. That is one thing you bear in mind. The body does not have any mechanism of metabolizing or eliminating this iron, apart from them being deposited in the organs of the body and causing damages. You can also see the importance of transfusing the exact blood components a patient needs. Now, patient that is anemic, okay, patients that are like sickle cell patients that receives blood transfusion over some periods of time. Okay, so it's very, very important. In situations where they can be managed with hematinics, they should be given hematinics. But in situations where we cannot do, we give them packed red cells. But in giving these packed red cells, we have to bear in mind about the consequences of iron overload to avoid damaging their organs. So before we go into blood transfusions for them, we must have used other mechanism of building their blood, okay, so that you don't really go immediately into giving the patient red blood cells because of this problem of overload. It's chronic as a result of chronic blood transfusion, repeated blood transfusion. So it's a complication of blood transfusion, okay, because these ions that are being deposited on the organs of the body damages this organ, damage the liver, damage the heart, damage the endocrine, damage the reticuloendothelial system, and rendering them non-functional. Okay, thank you. We'll stop here for today. If you have any questions, you can ask.